No, potentially not. That's fine. There'll be a larger Q&A session at the end that John will be involved in, along with the consultant panel, so we can come back a little bit later. Thank you very much, John. Moving onwards. So I'm just going to hand over to Mr. Ragbir Kaka, and he's going to do the introductions to the consultant panel.
Great, thanks. Firstly, thanks to both the Johns. John Taylor, who's been organising this and putting it together. It's a really professional setup, and thank you so much for taking time out to doing this. And then John Gill, it always amazes me when we have these talks together with our allied healthcare professionals and having a real synergy in the way that we treat our patients with ongoing pain. So that was a really exciting talk, and I think it marries in well with the talks we're about to have soon after this introduction. By way of introduction for myself, my name is Ragbir Kaka. I'm one of the other orthopaedic surgeons working very closely with Ali Noorani in running Orthopaedic Specialists. My area of interest is in lower limb deformity and sports injury, and I work out of Guy's and St Thomas's when I'm not working at HSH and with the Nuffield. Thanks. Next slide. So Ali was really modest in his introduction. I think he didn't really let on just how much effort he's put into getting the group together with Nuffield and working together with the team, with John, Taylor, Cannon, the whole gang in making this work. He's also a co-founder. He's a leading upper limb surgeon in Barts and the London, and he does a lot of teaching also. He looks after athletes, people from around the world, in managing complicated upper limb pathology, and he's widely published in all things upper limb. We're also going to introduce Stephen Humble. So Stephen's just to my right here. He's a consultant based out of Charing Cross and St Mary's, and he's together with Stefano. They're going to be providing our pain management for the Nuffield at Barts. He's a leading expert in pain management and anaesthetics, and is the medical director for the London Interventional Clinic. His main specialties are in spine interventional techniques, X-ray and ultrasound guided injections, as well as neuropathic type pain. So really excited to have him as part of the team. And sat further along to the right is Stefano. Stefano is actually a colleague of mine at Guy's and St Thomas's, and he also is a leading expert in all aspects of pain management. He does his main interest lies spinal cord stimulation, as well as all MSK pain pathology. So between the two of them, they will be handling all aspects of pain management for our team. So without further ado, I'm going to hand over to them to start their talks in management of chronic pain. Thank you.
Thank you very much, Ragbir. Thank you for the nice introduction. And yes, me and Stephen are the pain specialist for the group. And the idea of this talk that I think he ties quite well with the previous one is to describe in a kind of an interactive way what is the role of a pain specialist in managing persistent MSK pain. Now, in order to do that, and before actually getting into this, it is important for us to define pain and explain why a pain specialist is one of the best professionals that can explore the different aspect of pain. So I will leave it to my friend and colleague to describe what pain is and which kind of type of pain we have.
Thank you so much for that introduction, and also thank you to Jonathan for such an excellent introduction to both of our talks. He's really set the scene very well, and obviously we could go into more detail about all those aspects, but he's done it so well. We'll just sort of focus on other issues and just take it forward. So what is pain? Well, pain isn't just pain. There's much more to it than that. So pain can be a warning that something's wrong. It may be associated with tissue damage or may not be. As John mentioned in his talk, pain has a protective function. If you stick your hand in the fire, it's very hot, so you get pain, hot burning pain. You take your hand away and it stops you getting burned as much as possible. but it's a much more highly complex function phenomenon than that. It has descending inhibition and descending modulation. So you can turn pain down, you can turn pain up, and we'll come to that later in much more detail. Speaking of transmitting pain, you have many different types of nerve fibers, but the ones that are very specific for transmitting pain transmissions are the A delta fibers and the slow C fibers. And there are actually many different types of pain. As I said, pain isn't just pain. You can have nociceptive or physiological pain. This is typically associated with tissue damage and is typically acute. So it could occur after an injury or after surgery. You can have pain related to muscles. You can have lactic acidosis if you're training really hard, or you could have ischemic heart disease. So the heart is obviously a muscle, and you get muscular pain related to that. You can also get superficial, well-localized somatic pain. So if you cut your arm, for instance, that would be a good example of that. You get visceral pain. So angina is a really good example of visceral pain. So it's deep, poorly defined pain, typically central. And in the case of angina, it can travel down the arm, which is what we describe as referred pain. You can also have neuropathic pain. This is when you have a dysfunction or disorder or injury to the nervous system, and it doesn't work as well as it should do. So this is an introductory slide, really, to essentially say, how do we approach the management of persistent MSK pain? So we need to do a thorough assessment. This has often been done by colleagues such as John, but we will make our own assessment as well. We want to establish a diagnosis of what is going on to the best of our ability, and then formulate a management plan. So it's just, these are complex patients, but we try to keep it a simple, logical approach.
And in order to explain this with a more interactive example, we decided to kind of offer a kind of a spine triage pain example. This is because back pain, as you've heard in the previous lecture, is extremely common. It is most of the time benign, but it does affect the productivity of the most important part of the society. And it is one of the most common cause that bring the patient to see first an MSK specialist, and then if the pain is not resolved, then to see a pain specialist. So in these slides, we would like to show a potential algorithm on how to categorize pain, because low back pain, it is not a pathology, it's more like a syndrome. And there are some patterns that can be easily recognizable with an accurate history and physical examination. And once you have established those patterns, then you can offer a treatment. And most of the times can be interventional once you have established what could be the potential structure causing the pain. Now, we usually start with a history, right? And we ask the patient, where is your worst pain? People come with back and leg pain, but most of the times when they are properly interviewed, you can easily find that either the back or the leg are the most painful part. And that is important in our algorithm to direct the assessment and then the treatment. The second important question is to understand whether the pain is constant throughout the day and night, or whether it's intermittent. And when I'm saying intermittent, is then if the patient in any moment of the day at night can be completely pain-free. The other quite important question is whether there are some aggravating factors, specifically bending forward. Bending forward is a very specific maneuver for the lower back pain that increase the load, especially on the intervertebral disc, and release the pressure and the stress from the facet joints that are in the posterior part of the spine. So it's extremely important to categorize the patient whether bending forward increase the pain, release the pain, or doesn't make any difference. Of course, despite we don't put a lot of stress on red flags at the beginning of the assessment, it is extremely important all the time to check whether there is any changes in bowel and bladder function. We stress the fact any new changes, because most of the patient comes with some bowel and bladder problem. They are pre-existing their lower back pain. But new changes in bowel and bladder function with some let's say, hypoesthesia or dysesthesia in the perianal area, this is a red flag that requires surgical attention and will stop the pathway here. Then once we have a clear history, we move towards a physical examination, which needs to support what we have found during the history taking. And one of the most important tests is the passive or active prone extension of the spine. This is because and this is, as you can see from the picture there, means that either the patient actively extends the spine in a prone position, or whether the therapist does it when the patient lies flat. This is a quite sensitive and specific maneuver when passive to highlight microinstability in the spine, and is also a specific maneuver when active to highlight disc pathology, because especially if repeated multiple times, that release the pressure from the disc and improves some of the back pain that is disc related. Then the third step will be assessing some nerve root. So and these are quite common, so we test for the straight leg raising test, and that increase the tension on the lumbar nerve roots, and is positive mainly when there is a nerve root pathology. We test the motor function of the same root, and as you can see from the slide, we can use the knee reflex for the L4 nerve root, the toe extension, great toe extension for the L5, and the flexion for the S1. Since the patient is prone, then we can check the saddle sensation, as I said, to test the function of the sacral root. And it's quite important also to check whether there is any upper motor symptom that could clearly divert from an MSK pathology to a more neurological pathology. Now, once we have all these tests, we can kind of compile a flow chart where a patient can have 4 different patterns of pain. And according to those patterns, then we can move towards a potential treatment. So a patient has back dominant pain that it is intermittent and it is relieved by the flexion and is worsened by the extension of the spine, and he has a normal neurology. This is a pattern that we consider coming from the posterior part of the spine, facet joints, ligaments, potentially pars defect. And this kind of pattern does have some specific treatment that a pain specialist can offer. So, for example, I would ask my colleague Stephen, what would you offer to this kind of patients?
So this kind of patient, where the bread and butter of pain specialist work is often patients like this. So they have what's called axial back pain, so pain related to the posterior aspect of the spine, as you can see in the picture there, and this can be related to arthrosis or arthritis of the facet joints. So these are the 2 supporting joints or 2 stabilizing joints at the back of this, at the posterior or back of the spine. And so these types of patients would usually be managed with conservative treatment, such as physiotherapy and so on. And some of these may improve over time. However, the ones that do not, if they fulfill the criteria, as Stefano was saying, they could be a good candidate for injecting the facet joints. So the old-fashioned way of doing it, you literally inject local anesthetic and steroid with X-ray guidance into the facet joint itself. The more modern technique is you actually block the nerve that supplies the facet joint. And you can do this in the lumbar spine, the lower spine, in the thoracic spine, and of course here in the cervical spine as well. So you can see the diagram there where there's an injection going in, and they've actually injected contrast into the joint in the middle picture. And then, so that, essentially that's the old-fashioned way of doing it. The modern way is essentially you block the nerve that supplies the facet joint above and below the joint. And if they have a good response to that local anesthetic, it confirms the diagnosis, and that is the gold standard for diagnosing facet joint pain or facetogenic pain.
May I interrupt something here? Just to ask a very simple question. So we do, in the upper limb, right, we are very much reliant on the clinical examination, on assessing what's wrong before we rely on imaging. Generally speaking, and I'm not the expert in this, but quite a few of our spinal surgeons are focus on the MRI scans. But from what I'm hearing from you guys is that we haven't even mentioned the MRI yet, right? But a lot of it is clinical assessment.
Absolutely. Yeah. And so my approach, you want to have a history, which is consistent with examination, and then ideally you would have an MRI or other imaging, and that would be consistent as well in the absence of other things going on, so they wouldn't have widespread pain. And so that would be a good candidate for considering an intervention such as a facet joint block.
It is important to have the investigation after you have a clinical picture.
Correct, and which we do as well. But quite often, sorry, I won't interrupt for too long, but in the shoulder world, for example, as a pain specialist, that everybody literally has ACJ arthritis after a certain age, but it's often not symptomatic, right? Mm-hmm. So we don't focus on it too much. Quite a few people have labral injury, the pain may be coming from somewhere else.
And the spine is exactly the same. That's why you get an MRI, you're going to find disc degeneration, modic changes, facet joints are troubled. Mm-hmm. But if you don't have a clinical picture, what are you going to treat? The picture.
No, I love that. Thank you.
Thanks, Ali. Okay, so just following on from the previous slide, so if you have a patient, they've had the nerve blocked, they've blocked the nerve that supplies the facet joint, they've had a successful response to that, i.e. a dramatic reduction in pain. People can argue whether it should be 80% or a significant figure, but essentially they've had a good response to the technique and it's short-lived. You could consider radiofrequency treatment. If you've had a good response and it's long-lived, you wouldn't worry about doing radiofrequency. If you've not had a good response to the nerve block, then they would not be a good candidate for radiofrequency treatment. So this is a diagram that illustrates how radiofrequency treatment is applied. So you have a generator, which is connected to an electrode, which is connected to a special needle. The shaft of the needle is covered in plastic, the tip is metal, and you conduct electricity through a circuit through the patient's body and back to the machine. And there's a high density of radiofrequency electricity at the tip of the needle. So this then coagulates the tissue or burns the tissue right next to the needle. So if you place the needle just beside the very small nerve that supplies the facet joint, so you can burn the nerve and you can denervate the joint, just as as you do with the medial branch injections, the nerve blocks. You would burn the nerve above and below the facet joint as well. So just a little bit more background on radiofrequency, because there's different types of radiofrequency. I've just described this classic thermal radiofrequency. So you have continuous high frequency AC current, and it generates a temperature of 80 degrees Celsius, which coagulates the tissue. And it's the gold standard treatment for facetogenic pain, and you often have long-lasting benefit. If it wears off after some time, a year or 2 years or however long, you can repeat it as well. And it's a much better treatment than surgery. So surgery would not be a good option for facet joint pain. You get different types of radiofrequency. As I said, you can get pulse radiofrequency, so you have short pulses. And this allows heat to dissipate, and the temperature never gets above 42 degrees Celsius. So it's not particularly good for facetogenic pain, but just for information, it can also be good for other types of pain. It can be good for neuropathic pain. So you can try and dampen down a neuropathic or a hypersensitive nerve.
Oh yeah, so these are just a couple of very quick slides that I think OS is the only place in London, but probably in UK, where we can offer an additional version of facet joint denervation in case the percutaneous one doesn't work. So we can access the nerve supply of the joint with a small trocar, and we can identify the nerve and ablate the nerve itself. So this is something that you cannot find anywhere else. And this, I think, is another very good selling point for this group of interventionalists.
May I ask if you can just, for my benefit, why is that so good?
So
able to be so precise.
The problem is that the innervation of the facet joint is not as standard as we think, and some of the joints, they might have additional branches that come from a level above, or they might run on the periosteum. So with a radiofrequency percutaneous, you just place the needle and you hope that is the branch is where the needle is. With that one there, you can identify the branch, you resect it, you then burn both ends, and then you go all the way up to the capsule just to capture all the other small nerve endings that you might have missed. So much that when we do it for multiple joints, and we don't just do it for lumbar facet, we also do for the sacroiliac joint, and it's so effective that the patient feel like skin numbness for up to 3 months, because those are terminal nerve endings and innervates also the skin. While with a conventional denervation, you might have it, you might not have it.
And clinically, you see it being a lot more effective as well.
So yes, much more effective, especially in the patient that failed the percutaneous one, which is going to be always the first line of treatment. But also, we can provide this kind of radiofrequency treatment to multiple joints, right?
Yes, absolutely, Stefano. So this is one of my specialist interests. So this is a special type of radiofrequency. I think Ali might recognize this joint.
Yes.
Yeah, it's a knee.
Yeah,
yeah absolutely. Okay, so we're talking about cooled radiofrequency. So it sounds like a bit of an oxymoron, but actually it's not. So cooled radiofrequency means rather than being 80 degrees Celsius, it's actually 60 degrees Celsius, and it's cooled using a special system where water is circulated around the tip of the needle. And you think, well, why on earth would you do that? But actually, it changes the shape of the lesion, so you can actually have a larger golf ball shaped lesion, and it can make radiofrequency treatment more versatile. And it can be excellent for shoulder joint pain here. So if you look at the image on the left of the screen, so you can see the scapula there, you can see the posterior aspect of the shoulder, the nerve that comes from the top left corner. So you've got the suprascapular nerve there, and then if you go more to the middle of the picture, there's 2 orange dots, and there's a needle connected to those dots, and so that's the sensory branch of the suprascapular nerve. The motor branch curls round and goes more medially. So essentially, you're doing X-ray guided, as in the picture right beside it. So you take X-ray pictures or fluoroscopic pictures using a C-arm of the shoulder. You can identify the appropriate anatomy, and then you can make very targeted, very small, cooled radiofrequency lesions of just the sensory nerves, not the motor nerves. You can also take out a branch of the sensory branch of the axillary nerve as well. And this can be an excellent treatment for chronic shoulder pain. It can be good for people that are not suitable for surgery, so just comorbidities and so on.
So if you have somebody who has a big cuff tear, not medically fit, but has a painful shoulder.
Exactly, yeah.
You know enough of those, right?
Yeah, 1 or 2.
Yeah. Actually, it's a good point, because one of the things that we worry about, so suprascapular nerve blocks with steroid and so on are hit and miss, and sometimes they don't work, and if they work, they don't last that long, but they can be effective in some patients. The worry about radiofrequency obviously has been that if you have a candidate that may be suitable for a shoulder replacement later, what you don't want to do is mess up with the motor function. Even if it's a reverse shoulder that doesn't require the cuff as much, it still requires something. But this one, you're purely targeting the sensory branch. So.
Very, very purely, yeah. So if a standard suprascapular nerve block, you actually go from the top, and so on. Whereas we're way beyond that. And any procedure can have complications, but it has an excellent safety profile, and it's very specifically designed to target only the sensory nerves. It's the same with the facet. The facet, so you're only targeting the sensory nerve. You're not targeting a motor nerve.
And so you could use this for potentially patients who have even had shoulder replacements and is worn out a bit and has had retractable pain.
Absolutely. Yeah. I was just about to say that. Thank you.
I'm not a big shoulder replacement guy, but there's a whole burden of people who've had shoulder replacements that unfortunately not suitable for revisions, and then you're stuck.
Exactly. No, this is a good option. It's not a miracle cure, but it is a good option for these people. Sure. The same technology which I've just described can also be used for patients with chronic sacroiliac joint pain. You wouldn't do this if they just had a bit of SIJ pain. Obviously you would do physio and so on. But these are patients that have had injections of the sacroiliac joint. They've had a good response, but it's been a temporary one, and you want to get a definitive, longer-lasting response. And it's better than any other option, such as surgery and so on. So you make typically 9 discrete lesions all the way down to the sacroiliac joint. So the innovation for the sacroiliac joint, which is obviously you can see here, you've got only the sacrum, not the ilium, but nonetheless it's a good picture. So you have little nerves called lateral branch nerves, and they come from the L5 nerve, the S1 to S3 typically, and they go from the foramen, they branch off from the main nerve, and then supply the sacrum, which is why it's such a hard joint to innervate, because it has so many nerves supplying it, and if you miss one, you can still get the pain. So it's a real difficult one. And let's move on. Oh, cool, radiofrequency of the knee. Yeah.
Far more important joints.
Yeah, much more interesting. Okay, so we've got a picture there, a diagram of the knee, and we would target the genicular nerves, and the same applies. So you take a standard AP X-ray, you place the needles next to the sensory branches of the nerves, and then you confirm the depth by taking a lateral view. You can make 2 lesions per nerve. Again, it's not a miracle cure, but it can be particularly good for patients with chronic knee pain. So typically these patients would have had physio, they've seen multiple people, they almost certainly would have had steroid injections, local anesthetic and so on, but they may have only had a short-lived response to all these treatments, and they may not be someone who you want to do a knee replacement on for whatever reason, medical fitness.
Yeah.
Or
I mean, I totally rely on you guys for these particular kind of patients. So this brings the whole team together, right? So you've had a physiotherapist to have a look at them, tried hydrotherapy, tried all the different modalities, surgical review, just not fit for anything, or they've had surgery and they still haven't cured their pain.
Exactly, yeah.
And the total knee replacements, as much as we enjoy doing them, is very much an end stage procedure for me, and for a lot of my colleagues, it is literally the last resort. And we do know that up to 20% of knee replacements function poorly, and they're persisting pain, and 1 in 5 is a huge number. So out of that small percentage, where they have a smaller percentage of unexplained pain, I think this sort of modality works really well.
And you don't burn any bridges with this, right? So
that's the idea. I mean, any procedure can have complications, but these, very targeted, very safe procedures, image guide, and you're not going in willy-nilly.
Yeah.
There is no motor innervation in those small nerves. The only thing that you might lose a bit of proprioception. That's the only thing that, especially in older patients, you want to discuss with them about this. But and it's also quite good technique following the knee replacement in case they still have nociceptive pain. If then after the knee replacement they have purely neuropathic pain, then probably neurostimulation is more effective. And then it's the same algorithm that we are using for the back. We're going to use it for other joints. The whole point is mechanical versus neuropathic.
Right, yeah, very good.
And then exactly to keep following the same chart, right? So again, back pain patient this time with constant pain that worsened by flexion is most likely being a discogenic pain. And this is a big category of patient, young working patients, where if you look at NICE guidelines, Stephen, what is the treatment for these patients, regardless of the specialty?
Not very much, not much at all.
So what can we offer here that other places that cannot?
So the one thing that we can do, the one thing that really stands us out is that we can also do regenerative medicine treatment. We can treat patients with PRP, so plasma-rich protein, and also stem cell treatment using the lipogems technique. So we can inject mesenchymal stem cells into the disc, so we can actually regenerate the disc, and you can actually see changes on the MRI from this technique. And so it's an excellent technique. It's cutting edge. Some people would even describe it as semi-experimental, but I'm really excited about this technique.
But also, if you look at this is OS group, is one of the group in the world that has published more on regenerative medicine. So they've started with joint, like with knee first, but now they are expanding the indication. So what we've done, and the spine surgeon have done, they've just taken the experience that these guys had for knee for a long time, and we're moving to joints that are more complex to replace, like the spine, for example.
There's plenty of evidence now for example, tennis elbow with PRP. There is evidence for knees, and patients, and NICE has also published on it, but NICE do a good job, right? But the fact of the matter is you have to first get the evidence and do everything for them to then gather it and put together. So this probably is cutting edge for spine. Considering that the other option would be a major operation, which is a fusion or a disc replacement, which has very narrow indication that is not supported by NICE,
And even if it works, then in 30% of the patient develop adjacent level disease. So you just move the problem higher or lower, or both. So I think that this could be a good approach for discogenic patients. Then moving on the other side, if the patient has predominant leg pain that is constant, that is worsened by flexion, and this time has nerve root signs, then this is the classic radicular neuropathic pain patient. And even in this category of patients, as pain physician, we can offer a lot of treatment in between the conservative therapy and the most aggressive surgery, right?
Oh,
what can we do?
Absolutely, yeah. So this is our bread and butter. Essentially patients with sciatica, or what we would describe as a lumbar radiculopathy or radicular pain. So we've got an MRI picture there, and you can see there's a disc prolapse on the MRI. That's at L4-5 there, and if we can catch these people early, we can do a transforaminal epidural, so we can do an injection through the foramen or through the bony window, actually into the spine. So it's not just a normal epidural somewhere in the vicinity. We're actually doing it right next to the disc, right next to the nerve root. We can put local anesthetic and steroid in there. We can reduce the pressure, the inflammation on the nerve. And in many cases, we can actually avoid the need for surgery, and we can accelerate the physical rehabilitation as well. So it's a very satisfying technique to do. The other image that you could, so there's obviously a cartoon image which shows you where you put the needle there. Another one is an X-ray image, and you can actually you can see the needle there with the arrow pointing to it. We inject contrast. The contrast shows up as black on the X-ray there, and you can actually see the nerve identified by the contrast. You can see the contrast flow inside the spine and outline the nerve root, and it is such a satisfying thing to do. And
it also is an important approach, because the normal epidural that you can get anywhere, so you're injecting fluid in a small space, and the fluid tends to go where there is the path of less resistance. So the area where you have a conflict between the disc and the root, that usually is also scarred because of the inflammatory reaction, will not get a medication, will not get a steroids. While with this approach, you end up having a spread, and you can see with a lateral view, you can see the spread between the disc and the nerve root.
Yeah, it's got nowhere else to go.
Exactly.
Yeah.
Should do it properly.
We always do it properly.
Well, true. And then I think that the last pattern that we wanna describe is in the patient that still have leg predominant pain, but this time is intermittent, that is not triggered by flexion. Most of the times is triggered by activity, and usually are older patients. And these are the classic neurogenic claudication patient. So these are, again, commonly considered surgical candidates, but then most of the times are elderly patients. Then you order a scan because you want to understand what is the level that you would like to operate on. And most of the times you find multi-level stenosis. And so the surgeons are quite reluctant to do more than one level of decompression, because it requires multiple level of fixation if you destabilize the spine. While as a pain physician, we still have other approach when we can try to avoid surgery, right?
Yeah, absolutely. I mean, these are, the hardest of the hard patients, really, and they are, considering surgery, or you're trying to look at ways to avoid them having surgery. And while you can do a conventional epidural, you can do a caudal epidural, you often get poor results with that for the reasons we've just discussed. So we do highly specialized epidurals. So you do a caudal epidural approach, but you actually feed a nerve catheter up inside the spine, and you put it anterior or in front of where the nerve roots are. So you go in right beside the disc, and you can see the catheter go up with X-ray guidance, and you can inject special medicines to try and dissolve any scar tissue there. And it can be a very rewarding technique for these particularly difficult patients.
Plus, you can do more than one level.
You can do any level, yeah.
With a simple injection, we can target multiple areas according to the scan. So that is quite indicated for people with multi-level stenosis, for example.
And it's a very niche technique. Hardly anyone does this in the UK as well. So we're very proud to offer this.
Then the question is, what if your patient doesn't fit this 4 category that we have just described? So what is our role there? So I think we as a pain specialist, we can continue and further the diagnostic process here. So is where we then can order investigation, MRI, if patient had. We tend to order quite a lot of SPECT CT scan nowadays with some debate in the scientific community, whether it's actually showing a pain generator or not. We can provide specific assessment for small fibers. For example, quantitative sensory testing is another thing that we do offer. And we have the ability to differentiate what is left from that category, which could be mostly non-specific chronic lower back pain, which will require probably just analgesia as management and conservative treatment, and neuropathic pain, which could be in the chronic neuropathic pain in the back or down the lower limbs. And that one usually is treated with neuromodulation. So in terms of analgesia, Stephen, what would you advise for these kind of patients?
Okay, so there's not a simple answer for this, and I wanted to put this slide in the WHO or World Health Organization analgesic ladder, because this is what most people use for pain management. You think, well, fair enough, and so on, it's got a good reputation, but actually this ladder was invented for cancer pain relief around the world. It was not invented for acute pain, it was not invented for chronic pain or neuropathic pain, but it's essentially been used for all of these. And so I rarely use this now.
And really changed for 40 years, right?
That's right. And it's been part of the opioid epidemic, particularly in the States, but other countries as well.
Mm.
So
I mean, that's major, right? It claims like 80,000 lives a year in the US.
Oh yeah, I know, it's absolutely crazy. So essentially, I'll talk a bit more about what my approach is. So there are similarities. You can start with paracetamol and NSAIDs such as ibuprofen and various other ones as well. The only opioids I typically use are tramadol, buprenorphine, and tapentadol. I don't typically use morphine, diamorphine, fentanyl, oxycodone, any of these other ones. They tend to be the more problematic ones. Whereas tramadol, buprenorphine, tapentadol, they have a ceiling dose, so that you can only go so high, and they're very low addictive potential. For instance, buprenorphine itself is used for patients who are addicts to help control the addiction. Where an anti-neuropathics, of course. So if I identify that a patient has neuropathic pain or likely has neuropathic pain or features of it, we could use a tricyclic antidepressant, a TCA, and also gabapentinoids and various other very specific drugs as well.
Okay, and then probably the last few slides, we want to touch a bit about neuromodulation, which is something that I'm very proud of being quite an expert in the field, and is one of the very few techniques that NICE has recommended in terms of treating persistent pain. I won't do a lecture on neuromodulation, but technically it is a technique to try to interfere with the pain pathway from both the transmission of the signal, the processing of the signal in the spinal cord, and integration of the signal when it travels up to the brain. And then it is quite easy to do. I mean, it's inserting an epidural electrode with an epidural needle, exactly like we do injections. And we insert this catheter on the posterior part of the dural space, and it lies on top of the dorsal column. And when we provide stimulation, we stimulate both anterograde and retrograde, the dorsal column, and we interfere with the pain pathway. We can implant these leads virtually everywhere. You can see in the lumbar spine, the thoracic spine, in the cervical spine. We do retrograde for bladder dysfunction. So we can access virtually the whole spine from C1, C2, all the way down to the sacrum. Then we insert a small battery like a pacemaker in the buttock, and we connect it to these leads. It sounds like a big surgery, but he is very minimal invasive. He has got very small incision in the back of the patients, and if the patient is the right one and is properly selected, he also has a quite high success rate. I think we've given a kind of a general overview of what we can offer as a pain specialist in managing, diagnosis, assessing, the MSK pain.
Fantastic. I mean, look, for a pain talk, that was really, really good.
Right. Exactly.
And I've certainly learned a lot.
Thank you so much. Yes, well, do you want to jump in with that now, Rags? Yes, of course, please.
So, Stefano, you only really touched very mildly on the neuromodulation, and we know that's a massive part of dealing with pain, persistent, ongoing pain. And I think the guys would really want to sort of get more on that. Just really quickly for me, I mean, you say it's technically straightforward, but if a patient comes to see you, that is quite challenging to do. Is this a day case procedure? How does it work?
Okay, so there are two parts. We usually run a trial of stimulation where we insert the lead percutaneously. Day case, 30 minutes. I'm in the NHS, I do it on the local. Privately, we do under sedation for more comfort of the patient, but after 15 minutes, sedation wears off, patient walks home. Walks home with an external stimulator, and we then routinely follow the patient every 2-3 days for a week, 10 days, and only if the pain has improved. And when I'm saying improved, we look between 50 to 80% of pain relief at least to justify to proceed to the next step. Then we proceed to the next step. The next step could be, again, day case or a inpatient procedure where we make 2 small incisions, we insert the wires, we suture it on the supraspinal ligament, and we tunnel it on usually down to the buttock, and we insert the battery subcutaneously. So it is a very, very quick and easy procedure to do.
Thank you.
And then you are planning to do a more detailed talk on this as
Yes.
well. That'll be interesting. Yeah.
Thank you.
With some evidence around it, so show some data.
That was absolutely incredible. Thank you so much, Mr. Ragbir-Kaka, Mr. Ali Noorani, Dr. Stephen Humble, and Dr. Stefano Palmisani. That was brilliant. Jonathan Gill as well, phenomenal. I'm actually blown away by the content there, and just the depth in an overview was incredible. We got everything there. It was really good. The things that were really refreshing for me to see were that this is a group of consultants who are conservative in their management approach. You know, the way that they don't rely on, purely imaging, that they want to do that thorough workup, that history taking, that diagnosis. And that's one of the things I found working with the OS group of consultants who are coming on board to offer our orthopaedic services and will be Nuffield Health consultants at Nuffield Health at St. Bartholomew's Hospital, is just their incredible diligence and how much they are in line with our values of patient care, doing the right thing and putting the patients first. It's absolutely incredible, really refreshing to see. And yes, thank you so much to all of you and to John Gill. They've all put an incredible amount of time into this evening, and I'm sure it's been very well received. We are going to move on to a live Q&A. Just before we do that, I want to take this opportunity to tell you about our upcoming events. So next up on Wednesday, the 20th of October, we have the Evaluation and Diagnosis of Rheumatological Disorders with Dr. Gagandeep Thakkar. Now, this event is going to be a case study session. We've had 2 really interesting case studies submitted already. As participants on our talks, if you do have an interesting case within the realm of rheumatology, either where you've referred someone on and it's been the right call, the wrong call, or you're not sure and you would like to present it on that talk, there is still a slot for another case study to come through. I'll pop my email up in a moment. Please take a note, and that would be fantastic to see. On Wednesday, the 3rd of November, in this room, Mr. Ragbir-Kaka, alongside his colleague, Professor Adrian Wilson, will be looking at the management of meniscal pathology. That will be alongside our Nuffield Health physiotherapist, Chris Davis, who's got a master's in sport and exercise medicine and is great within the realms of knees and meniscal pathology. He's also part of our learning and development team at Nuffield Health that helped to put this event together today. So it would be brilliant to have him on board. On Wednesday, the 17th of November, also in the room, Mr. Ali Noorani, looking at the management of shoulder pathology alongside Professor Roger Van Ria, an incredible panel of consultants. They're leading lights and experts in their field, as with all of the talks. And Sharif Marzouk, the lead physiotherapist at Nuffield Health at St. Bartholomew's Hospital, who's also an upper limb specialist, will be joining us for that panel. Very exciting. We're then looking at pelvic health conditions, so women's and men's health, looking at conservative and non-conservative management options with Miss Charlotte Challier and Joe DeFawn. So again, a leading light in the world of pelvic health with Miss Charlotte Challier, and Joe DeFawn is our national lead for pelvic health physiotherapy within Nuffield Health. Finally, the Christmas special. So Wednesday, the 15th of December, we've got sport and exercise medicine. So that's going to be with Dr. Shabazz Mughal, who is incredible within the field of sport and exercise medicine and has an incredibly extensive CV. Tom Codrington will be joining him, and he is our lead ALP, or one of our lead ALPs, and again has a master's in sport and exercise medicine, and again that's going to form an incredible panel for that event. My email is there at the bottom, so john.taylor@nuffieldhealth.com. If you'd like to get more information, again, a lot of you signed up via our internal Nuffield Health Academy, a few of you via Eventbrite for tonight's event as well. You can still do it via those means, but if you've got any particular questions, then please obviously pop me an email. We are looking to put together tailored CPD programs that work for you. As you've seen this evening, we have access to leading university teaching hospital specialists who are at the top of their game, and they're coming on board to be our consultants at Nuffield Health at St. Bartholomew's Hospital. It's a really exciting time. We're shaping the pathway and what our education program is going to look like, and we really want you to be part of that. We will be doing hospital tours in due course when it opens early next year. I would love to get your feedback on the event tonight, and I will be sending you all out a feedback form. If you could please take the time to fill that in, that would be fantastic. And if you require a CPD certificate after today's event, again, just pop me an email, and my email is on the bottom there. Thank you very much, everyone. So we're going to move through to the live Q&A and a bit more of a panel discussion. Now, for this to work well, what I'd like you to do is to pop your questions into the chat if you have any. If you would like to say your question out loud off mute, that's absolutely fine. I understand that's often easier. If you could just pop that in the chat so I can just go through in a logical order with those questions, then we can invite you to come off mute in order to do that. So yeah, if you'd like to pop any questions that you might have into the chat, and we can start to pose them to our fantastic panel here and to John Gill over at Nuffield Health in Moorgate. So we've got a couple of things actually on here already. So Fed and Dave, we've got, what is the name of the test to assess disc pathology with 80% specificity, put my teeth in, and 90% sensitivity, the one requiring back extension, so the one in prone there?
So I wish there was a test to assess disc pathology. That is a test to assess micro instability of the lumbar spine, and it is called prone extension test. It could be passive or could be active. The passive one is the one that has 80% sensitivity for lumbar spine instability. The one that is active has got more specificity for lumbar disc pathology, but is with a passive one, you simply have the patient lying prone, and you, from the back, you lift the leg and you kind of rotate the pelvis. And with the patient, asking the patient to relax the muscles, and that usually create a abnormal movement of the lumbar spine in case there is instability, for example, a pars defect. With the one that is active, you will ask the patient to repeat it, so to extend the spine from the prone position, and you ask that the patient to repeat this test multiple times. And usually after 3, 4, 5 times, if there is a disc-related pain, the pain starts to improve, because that usually offloads the lumbar disc from the pressure. As soon as the patient then stand up, the pain comes back. So it's just a test.
Fantastic. Thank you very much. A couple more questions that have just come through here. So Sharon Housby, who's our regional lead physiotherapist for London, has got a question for John Gill, which is, what are the key areas of research regarding the CFT approach? So if people want to do a bit more further reading on that, where would you direct them, John?
Okay, thanks, Sharon. I'm just literally putting a link into the chat there for the sort of key article. It's really big, sorry about that. The guys that sort of formulated and have tested and put CFT into education released an article in 2018 that sort of summarizes the approach. My presentation sort of leaned heavily on it, so I put the link in there. And the group they're global. There's around about 20, 30, perhaps sort of PhD students from all over the world, and they're releasing various different research articles around the sort of those areas I mentioned, like beliefs and testing implicit versus explicit beliefs, as well as releasing podcasts, infographics, PainEd. I think it's pained.com is a fantastic site to look at for that. So I'll put that in the link shortly as well.
Fantastic. And another one for you here, John. So Jodie Breach is very keen to get your thoughts on the common approach to lower back pain of core stability and motion control, sort of one facet, versus how that contradicts with the CFT approach.
Yes. So I feel like I've personally been through the journey of the sort of the phenomenon of core stability and instability, because I sort of studied in 2002 to 2005 when the sort of theory was really, really emerging. And I did an undergrad's sort of project on it, and then sort of qualified when it was all becoming really, really sort of exploding and back classes with lots of bird dogs and you know, activating transverse abdominis. I found it really hard to apply and to practice. Really, really sort of fiddly sort of approach in terms of palpating, and you know, personally, I found it hard to activate my transverse abdominis while doing lots of movements. And then back in 2008, they did a systematic review that showed it was no extra benefit to general exercise. And that was repeated in 2014. So I think that's about the time that it was really exploding in terms of clinical practice. And again, they found that it wasn't any extra sort of magic special treatment outcomes compared to general exercise. So that, coupled with the idea that a lot of our distressed, disabled, low back pain patients actually have more guarding, more bracing, more protective sort of behaviors, the idea of reinforcing that by telling them to suck their belly in, or be mindful of the things that they do, it kind of feeds into the problem rather than taking away from it. So, and back in the early 2000s, Peter O'Sullivan, who's now the biggest sort of known figure in the area, was releasing papers, you know, around stability and things like that, and writing chapters in books. So he's completely U-turned about it, which is a pretty sort of, you know, special thing to sort of make a complete U-turn in a career when you're leading the research on it. So yeah, that's my sort of take on that part.
Yeah, absolutely. It takes something special to go back and redo your life's work. And well, he's still got plenty, obviously, of research in him. But no, that's a fantastic answer there, John. Very thorough. Sharif Marzouk, our lead physiotherapist at Nuffield Health at St. Bartholomew's Hospital. You want to ask a question off mute. If you ask me the question, I will repeat it out to the consultants. I won't do it live because you'll get too much feedback on the microphone. But do you want to pop off mute and ask that question?
Hi, John. Thank you. With facet joint pain, say for example in the neck, it's not uncommon to also have an element of arm pain or posterior shoulder pain, for example. How then does radiofrequency intervention, which addresses the sensory element of the facet joint, of the innervation to the facet joint, how then does that then improve radicular pain or arm pain?
With you. So I'm probably going to butcher this question and asking it out loud now, Sharif, but thank you for that. Sharif is asking, if you're doing a facet joint injection and you've also got radicular pain, how does radiofrequency work in those circumstances when you're trying to also target, say, an upper limb pain? Is that a fair summary of your question there, Sharif?
Yeah, John. Yeah, it's just that the radiofrequency addresses the sensory input to the facet joint.
Absolutely, because the radiofrequency is addressing more of the sensory input.
So the thing is that the radiofrequency is addressing the nerve supply of the facet joint. Is not addressing anything related to the nerve root. So it is important to understand the pain generator before discussing an intervention. So if the patient has facet joints pain with referred pain down to the lower limb or the upper limb, then you need to target a sensor innervation of the facet joint. If the patient has a radicular pain, then that is what you need to address, and potentially the facet joint injection and or the innervation is not the right treatment and is more like a transforaminal injection.
What if you have both? Can you do both?
So in theory, you can do both, but it's unlikely that as a pathology, you have facet joints mediated pain and acute subacute disc prolapse. It can happen, but it's unlikely. I'm afraid I have to say that is a very common practice to put a patient asleep and you inject everything everywhere. It will improve the pain for 3 months. The pain will come back and the patient will not have an answer why it's coming back, and he won't have a long-term treatment plan.
That's great, thank you. And that sort of leads in, I think, to this next question, looking at more of an MDT approach. This is from Chris Davis. So he's asking to Dr. Stephen Humble, you mentioned earlier that epidural injections for radicular pain are effective if they're caught early. We know that people suffering with typical radicular pain generally will resolve with a wait-and-see approach alongside some physiotherapy support exercise approaches. In your mind, is there a subgroup of these patients that you believe that this conservative step should not be included or trialed first in order to proceed with the early referral for the epidural injection?
Thanks, John. It's actually a very good question, very clear question as well. And I'm certainly not advocating that you refer everyone with sciatica or radicular pain for an injection. I think it is entirely reasonable for, and as a physiotherapist, I'm sure you're seeing many patients like this, for you to try conservative approaches. First, and if the pain's not so severe, it's more mild or moderate, and everything's going in the right direction, then it'd be reasonable to continue with that. However, if it's particularly severe, if it's debilitating, you want to have a more aggressive approach. It's as simple as that. So you'd want, if it was if you were the patient and you had really severe, if you had mild sciatica, do you know what, I'm not that bothered for an injection. If it's very severe and you can't do anything, you would want to have an injection. So it's really as simple as that. And you would still do physical rehabilitation whether or not you have the injection as well. So it comes as a package.
And that's great. Thank you, Dr. Stephen Humble. It's a difficult one, isn't it? Putting my physiotherapy hat on there. That is, how do you catch those people early enough? How do you know without trialing that conservative management first? There's always going to be that wait and see. Obviously, you've got some individuals who will rapidly regress, and then it's quite clear, or they'll be coming to you. But it's the wish list to have that criteria to be able to spot those people before they start to slip off, so that they can get to you before their pain is elevated beyond those levels. But very, very difficult to do. Are there any further questions? I can't see any more on the chat, and we'll just give it about 60 seconds or so, just if anyone has got any more questions. But we are doing incredibly well on time for our 8:30 finish. I'd like to, almost like we planned it, I would like to thank everyone who has attended today, especially all of you sticking right to the end here for the Q&A is absolutely fantastic to see. Again, I'm just going to jump back here. If you do have anything that you want to ask to the consultants after this talk, use my email and I can get that message through to them. Again, a reminder that I would love your feedback. I'd love to know what you want next from this fantastic group of consultants coming to work with us at Nuffield Health at St. Bartholomew's Hospital. And also, please do get in touch if you would like a CPD certificate for this event. A final huge thank you, as we haven't had any more. Oh, we've got a question. Well done, Olympia Ardeline, just in the nick of time there. So what would you do for spondylolisthesis? Would any of these would suit more than the other? So I think in terms of a management approach for spondylolisthesis is quite a broad question, but does someone want to take that one?
I can take this. So this is a very classic surgical pathology. So unless the patient is extremely old and is any surgery, a very few operation the spine surgeons perform and works extremely well. So we strongly advise to leave it to the spine surgeons.
I mean, that's a really good point. And in each of our specialties, as a group, we have come together to say we're not precious about all operating on patients. I mean, I've looked at my numbers. I end up operating less than 20% of my patients. But because I have you guys, we have physiotherapists and so on, we really see our role as actually figuring out what the problem is. I mean, you guys, physiotherapists, can do that as well. But sometimes, either patients want to see a consultant for some reason to reassure themselves that nothing's been missed, or there's a second opinion from us. We are here mostly to reassure and help facilitate the management. And quite often it is conservative and non-operative. But there are certain pathologies that, you do have to fix, Just thank God we're surgeons, right?
I think just to wrap up on our side, I think what we've had a really good overview today is a holistic approach to what we want to manage. We've had the views from John, managing it from a mental health perspective, physical therapy perspective. We've got the interventional perspective as well. And all of these therapies have had the patient at the center of all interventions. And I think that's what we're trying to achieve. And I think it's a really exciting collaboration for our teaching moving forward. And hopefully they'll follow in the same vein. So thank you so much.
No, thank you. So thank you very much, everyone. That's it for this evening. And a final big thank you to John Gill over in Moorgate, to Mr. Ragbir Kaka, Mr. Ali Narani, Dr. Stephen Humble, and Dr. Stefano Palmisani. Wishing you all a lovely evening. Thank you and take care.
Thanks.